Hi, Dr. Jarrard.
Hi, Darryl.
Hi, thanks for being part of this conference. We really appreciate your time. Love the plant in the background. Really good. We're brothers in horticultural here. Can you tell us what kind of doctor you are and where you do what you do?
Yes. So my name is Dr. David Jarrard. I'm a urologic oncologist, so a urologist with a specialty in cancer. I practice at the University of Wisconsin and also our Comprehensive Cancer Center. And really my work and most of my interest focuses on the interface between sort of localized disease and more advanced disease, and coming up with better strategies to help men that are transitioning or that have presented with this kind of disease.
And so how many times a week do you see patients? How many days?
2 typically, and then operate about a day and a half as well.
So today we're going to be talking about what happens to men after they see a rising PSA after their initial treatment. So of your patients, like, a rough estimate, what percentage of folks come in after they had surgery with you, but their PSA is popped?
Yes. So probably about 20% in my practice. As a urologist, we serve as somebody who helps transition patients to our medical oncology colleagues, which typically deal with more advanced cancer. So when we have patients that may have a rising PSA after treatment, either radiation therapy or surgery, and obviously the PSA plays an important role in this kind of situation. The PSA is not it's an acceptable marker for prostate cancer. It's not particularly the best, but it's sort of the best we've got as far as detecting it. But realize that in this post-operative or post-radiation situation, it's a very sensitive marker for the presence of cancer cells. The PSA is produced by the prostate as well as the cancer. The prostate, for patients that have had surgery, has been removed completely. So if there is any detectable PSA after surgery, it can indicate a PSA or a cancer recurrence.
So when a patient sees that or hears that the word recurrence, that's sort of married to like either expressed or hidden thought of why me? What do you say to somebody who says, why did that happen to me? I thought you took care of this, or the radiation oncologist took care of this.
Yeah, can be a very concerning area. And, anytime we're dealing with cancer, I view it as sort of a race, hurdles, if you will. And always the hope is that, there just be one hurdle to jump over, and then you can continue on. But in many situations, there is you may encounter other additional hurdles in your cancer journey. And I view sort of the recurrence or rising PSA as one of those situations. So realize that always when we do surgery or radiation, the goal is cure. But there are certainly situations where the cancer may come back, with any cancer, breast, colon, you name it. And but we do have a lot of strategies to present for these patients.
And that's good that that there are options, and we'll get to those in 90 seconds or less or so, or maybe 2 or 3 minutes. But let's focus a bit on what happened. And it's appropriate for patients to feel disappointment or other kinds of negative emotional responses to learning that the surgery or radiation or brachytherapy kind of things or whatever they were doing just didn't work. But is it that it didn't work, or it never could have worked, that there was something biological or genomic or genetic or something inside the man that surgery and radiation just was never meant to address?
These are typically very effective therapies. But realize that most of these therapies are treating localized disease. So within the prostate, or in the case of radiation or surgery, will occasionally remove the lymph nodes as well. In these kinds of situations, there may be cells that have escaped outside of the prostate that are potentially still in the pelvis, or they may be elsewhere, that are really below the level of detection as far as any imaging is concerned, or any other mechanism before treatment. So when you see a patient with a rising PSA after surgery or radiation, the assumption is not so much that the treatment didn't work, the application of it, but the fact that there are some cells outside of the field of treatment that are causing this increase in PSA in the recurrence.
Is there any thinking that that some people have one type of prostate cancer and others have another type, and we just don't know how to differentiate one type from the other?
Yeah, Darryl, that's a good question, and we're learning more about how prostate cancer responds. When we think about cancer treatment, one striking thing about solid tumors is that they tend to be heterogeneous. That is, it's not a homogeneous collection of cells. These cells often contain slightly different changes, and in a situation where you do a biopsy, you have a sense of what the tumor is, but it doesn't necessarily give you the whole story. And there may have been cells that had leaked outside of the prostate that were slightly, that had those genetic changes that would enable that. And realize, and this is an important point, it's very difficult for prostate cancer cells to move outside of the prostate. There are a number of different steps they have to go through in order to do that. And, a common question we get asked is, does prostate biopsy cause the cancer to spread? And there's really no data to suggest that. There are over 1 million biopsies that are done annually. And again, there's no evidence to suggest that. So this is actually, when this does occur, it's the inherent biology of the cancer that's causing this. Now, you're speaking some to this question of, can we come up with molecular testing that might better stratify who might respond to radiation therapy or surgery? And I think that to a certain extent is in its infancy still. We're learning more about these cancers and how they respond. But at the present time, often most of the decision-making is appropriately done using the PSA, the clinical stage, the grade of the cancer, and then imaging as appropriate.
Okay. So, and I guess there are people who are going to wonder, did I do anything wrong?
Definitely no. I mean, it is, these cancers are ones that develop with aging. Prostate cancer is the disease of aging first and foremost. To a certain extent, it's just bad luck. The fact that some of these develop. There are, we do the best we can as far as counseling patients with regard to diet and other components that may help in slowing down the growth of these. But it's not anything inherent that a patient does wrong. It has more to do with just the behavior of the cancer.
Okay. So now I'm sitting in your office, or hundreds of patients over the years have sat in your office, and you're looking them in the eye, and you know that they're concerned. Why am I even sitting here again? What are those conversations like?
Yeah, so the first is to realize that we may have additional treatment that's needed. Often a patient will come in with a single PSA test after a treatment, So the PSA, for example, after surgery may go down to a very low level, typically undetectable or less than 0.1. And it may at some point during their follow-up begin increasing. And it's usually in the first 2 years that is going to occur. The most important thing to do, first of all, is to recheck the PSA and realize that there can be, although it's a prostate-specific antigen, there can be false positives that may contribute to the PSA background. For example, individuals who've had dental work, for example, a root canal or inflammation, the parotid gland produces a little bit of PSA. Individuals with urinary infections recently may have an elevated PSA as well. So it's important to rule out those issues and serially check the PSA. And really what we look for is not only a single increase in the PSA, but multiple increases in the PSA. And how frequently these are checked as far as determining or trying to determine whether there's a failure depends on the clinical situation, and most doctors can provide specific recommendations for that.
So what are the recommendations that you provide?
Well, a lot depends on how far out from the treatment the individual is. It's also important to realize that the issues like grade play a role with this. For example, individuals that have higher grade cancers, and I know we often talk about Gleason grade, but your readers are familiar with grade group as well at this point?
Yeah, the Epstein things and all that. Oh, yeah.
Yeah, so patients with higher grade cancers, grade group 4 or 5, often the PSA rises a little bit more quickly in that situation. So we may check the PSA every 6 weeks in that situation if we're trying to determine whether there's a PSA failure. It has, in these patients, so typically we'll follow the PSA for a period of time and make certain that this is in fact a true rise in the PSA. When we get to this point, the question then becomes, where is where could these cancer cells be? And there are a number of features that play into this. As I mentioned, higher grade cancers, if you had that originally on your pathology, it's more likely to be somewhere else, potentially in the lymph nodes. Lower grade cancers may be just locally in the area where the prostate was. The PSA at the beginning of your treatment is important. How quickly the PSA is rising is very important. And individuals who have, for example, PSA doubling time, this is a calculation of the PSA change over months or time. If you look at PSA doubling time, we tend to get more concerned if individuals have a PSA of doubling time of less than 6 months. So that's something that's important. The other thing, Darryl, that it's important for patients to realize is that not all recurrences necessarily need to be treated. And I actually have a number of patients whose PSAs are rising very, very slowly in this kind of setting. They have doubling times on their order of 3 or 4 years. And the biological behavior of those types of cancers are typically very prolonged. So, if you're older and you have a rising PSA, there are situations in which we'll just watch this rather than treat it.
Okay, so that is actually almost like a gold star question. What kind of person does it take to jump into a therapy, like an androgen deprivation therapy, or start thinking hardcore, I got to do something, or put themselves in what in essence is an active surveillance frame of mind and continue to lead their life that they expected to lead after initial therapy, after initial treatment.
Yeah, we talked about some of the grade of the cancer, the rate of rise. When it begins to rise is important too. And it's interesting that there are situations where a patient may have a PSA of 0 for quite a few years after treatment. and then it begins rising. And often in those situations, it's a very slow rise. Many of the patients that we see with an immediate PSA recurrence after surgery or radiation, again, suggest that the cells are likely somewhere else in the body rather than the area where the prostate was. So when you think about this context of watching it, the rate of rise of the PSA is important, the age of the patient, the expected longevity. For example, if a patient has had another serious health event that may limit their potential longevity, it's likely the prostate cancer, if it's slowly growing, is not going to necessarily create an issue during their natural lifespan.
Yeah. Do you have these conversations just with the patient, or like spouses, partners, sons, daughters, aunts, uncles, whatever?
Yes, it's critical to have another set of ears in the room. And the reason is, obviously having a health advocate is really a great thing. And sometimes patients will come in with a wife, a significant other, sometimes bring in a fellow cancer survivor who may have gone through this and is there for counseling and help. All of these can be really useful.
And we talk with everyone about the disparity that Black men face around prostate cancer. Is there an elevation of concern for Black men presenting in front of you, both with the idea, like, I'm a Black man and people are telling me I'm vulnerable to death more often than white men are, and second, like, there's something, not particularly with your specific care, but is there something about racism or the way the healthcare system is sort of loaded slightly against Black men that influenced this outcome?
Those are good questions. And there's some really interesting data that's been published in the last couple of years that suggests if patients are in a healthcare system, and this is actually published out of the VA system, the Veterans Administration System. So men have equal access to healthcare in that, whether you're white, Black, or whatever. In that kind of situation, Black men and white men actually do equally as well, respond equally well to treatments. So part of the issue, it may not necessarily be biology of the cancer in Black men, but it may actually just be other socioeconomic factors that are causing them to present later for care. And that's an important thing to realize. And we're learning more about these kinds of issues. It's very interesting. There was a study done, published about a little over a year ago, by an individual, Dr. Dan Spratt. He's at Michigan, looking at patients who got an immune type of therapy. It's called Provenge or Ciplas-LT. And men that actually, Black men actually responded better to that treatment than white men and other races, suggesting that there may be a more immune friendly type of component to their cancer. So there may be situations in certain types of treatments that we would direct in, based on race to one individual or another. But it really suggests that a lot of the care that we deliver for Black men works equally as well for Black men or white men.
So now let's talk about the actual therapies that are on the table for guys presenting with an elevated PSA after initial therapy. And I guess the first question anyone should ask, or anyone wants to ask, is how much longer have I got to live in that space? So what do you tell them? So
there was a study done a number of years ago looking at survival in patients with a rising PSA. And the average survival was 13 years, the average. And this is before a lot of the newer treatments that we now have. And realize that, in the past, 5 to 10 years, we've completely changed the way we treat advanced disease. When I started my career, we had one drug it was called docetaxel for advanced prostate cancer. We now have 12 and counting additional drugs that target a number of different mechanisms. So the natural history of prostate cancer tends to be slow. I mean, this is not lung cancer, it's not pancreatic cancer. It's sort of a different type of cancer in general. And we do have a lot more treatment options. So that's really the first thing that patients need to realize. The other thing is, when you think about steps before treatment, and we can get into treatment options, certainly. We talked about the number of things that serial PSAs. It's important that imaging is now playing more of a role in men with a rising PSA after surgery or radiation. So PET scanning is probably the most important development that your readers need to be aware of in the past few years. There are a number of different PET scans, and it gets very confusing for patients to sort through, what's a good PET scan for prostate cancer. So the first thing to realize is that not all PET scans are made equal, and that they're not all good for all cancers. When it comes to prostate, there's sort of three types of PET scans that people need to be aware of. The first is something called PET choline. And this is basically just looks at how the tracer is developed and metabolized by the tumor. So PET choline is probably the least sensitive of the three newer types that we have. A very common one that's used much more widely than PET choline is called flucyclovine, PET flucyclovine. It's also known as oxamin, so an oxamin scan is a much more sensitive than the PET choline, and it can pick up even low PSA levels where the cancer is. And this can be useful for the physician, treating physician. The third that your readers should be aware of is the PSMA PET, or prostate-specific membrane antigen PET. This is the one that got a lot of press in the last few months. It was just FDA approved. We had it in trials here for a number of years, and many places have been working with it. So we're all familiar with it long before the FDA approval. But this adds another log of sensitivity as far as picking up recurrent cancer at very low levels. So in these situations now, often what I'll recommend to our patients is considering getting a PET scan. Often we'll lean toward a PSMA PET scan. And the reason that's important is it can tell you where the cancer is. So for example, if you do a PSMA PET scan and you see an area of uptake in the area near where the prostate was, and somebody's had their prostate removed, you can then apply radiation to that area and potentially treat it. Conversely, if you do a PSMA PET scan and it's in some lymph nodes farther up the lymphatic chain, we may lean more towards systemic therapy in that kind of situation. So that's been a major development really in the last year.
And it's a major development for the United States. PSMA has been practiced in other countries. So in a way, we're a bit laggard in that, but good that we got it now. And and not to be confounded by I mispronounce this endlessly. Lutetium. Lutetium.
Yeah.
Okay. 177 or 177 lutetium. Is it 177 or lutetium?
177 lutetium.
Yeah. Okay.
Yeah.
Which is combined with sort of with this idea of identifying a location and acting on it in an aggressive way at the same, as almost simultaneously. We do have two other talks about that. Dr. Calais and Dr. Gamo also speaking on that. But that's not what for the space and the kind of guy that we're talking about right now. Correct. Which are, I mean, those are guys who are no longer hormone sensitive and they have distant metastases and such. Today's guy is sort of like in a new world. at the cusp of this new world where you're dealing with what you imagine cancer actually is, metastases that have left the home ground and are now out to kill you. But there are things you could do to get beyond that 13-year average lifespan. And why don't you tell us more? Let's spend 5 or 10 minutes just laying out what people should be asking their doctors about now.
Yes. So really the first decision in this kind of setting is, am I a candidate for radiation therapy? And after surgery, if you have a PSA failure, generally, and I'll speak briefly about this, generally, if you've had radiation and the PSA begins to rise, it's a more complex situation. Often it suggests that the cells are somewhere else outside of the area where that was radiated. And you're more likely to institute systemic therapy in that kind of setting rather than any type of additional therapy. You can't deliver more radiation to a radiated field. The tissues begin to break down and they don't tolerate it. But for men that have had surgery, if the PSA begins rising, really the question becomes, am I a candidate for radiation therapy in this setting? What we call salvage radiation therapy. And that will depend on the rate of rise, the absolute PSA, the initial grade of the cancer, the imaging. There are a number of things that your physician will take into account with regard to making this recommendation. This radiation is typically a little lower dose than in the primary setting, and it's often delivered over a number of weeks. Side effects that can be associated with it, men will often have some worsened urinary symptoms transiently, and they often improve after a period of time. And the other is increased sort of bowel-related issues, diarrhea, things like that. Again, often are more significant during radiation that generally improves over time. So in general, this kind of salvage radiation is tolerated well. And if there's evidence to suggest it's in the area of the pelvis that can be treated, that would often be instituted.
Okay, and what would be another set of choices for people?
So the question often becomes, should I start androgen deprivation therapy? And this is a difficult situation for patients because they'll often see their PSA rising. You want to do something, but when we look at the data with early instituting androgen deprivation therapy early on, so for example, if the PSA is 1 or 2 and rising, versus waiting till it's higher, there's not really much difference as far as survival. And realize that androgen deprivation therapy, although a necessary medicine in many situations, there are some potential side effects with a longer term use of this drug. So there's been our newer guidelines through the American Urological Association. I sit on the guidelines panel. We just we've made the recommendation that in a situation where the patient is not a candidate for radiation, that if the PSA is rising, you can actually continue to watch this for a period of time rather than starting androgen deprivation therapy immediately, just given the fact that there's not much difference as far as cancer outcomes. And your quality of life is better. And, obviously, Darryl, for all of your viewers, that's an important issue. It's not just quantity of life, but it's quality of life. That's very important.
So most people in our support group, and, we have, like 77,000, I think we're approaching 78,000 people who have used our services just during the last 12 months, in this time of COVID. That's elevated significant. Well, it's a mixed bag of bragging rights and like sadness, that there's that much demand for information and online opportunities have become prominent because of COVID. I think, the idea that people that want to preserve quality of life in the face of what in effect is chemical castration is something that absolutely stuns people when they hear it. And yet people manage. What guidance do you give people who you put on androgen deprivation therapy, or what's known as hormone therapy in more common lingo? What kind of guidance do you give as far as preserving quality of life?
Yeah, so it's important to think about bone density, and patients should consider supplementation with calcium and vitamin D, weight-bearing exercise. So, again, this kind of situation where exercise is good, and weightlifting, other kinds of physical as well as cardiovascular exercise is important. I think diet plays an important role in this as well. We routinely have our patients in this kind of situation meet with our cancer nutritionist. And it's not so much supplements. And we tend to shy away from supplements just because some of the adverse effects associated with them. But really focusing on sort of whole food nutrition, a lot of fruits and vegetables, minimizing sort of red meat intake. I think from the standpoint, there's been some interesting data with regard to, for example, pomegranate juice. We were involved in an early trial that we had published about a year ago on this. And also, I would say that vitamin D supplementation, especially for those of us in the northern climates where there's less sun, vitamin D supplementation deficiency is often a common finding. So those are the kinds of things that we really encourage patients to focus on to improve their quality of life on androgen deprivation therapy. And most doctors will keep an eye on bone density, but you can help limit that again by exercise and these kinds of factors. I'll say also there are specific situations where patients may be candidates for what's called intermittent androgen deprivation therapy. So this is a situation where in a patient with a PSA that is rising and there's evidence of disease outside the prostate, they may start androgen deprivation therapy and usually continue it for 6 to 12 months and then stop it. And so what happens is the PSA goes down, it stays there for a while, and then begins to increase over time again, as expected. And the advantage about that is there are sort of drug holidays, if you will, where you're not necessarily exposed to some of the hot flashes and other side effects associated with androgen deprivation therapy. Your libido is better. So that is a possibility for some men as well under selected situations.
So at what point, so we're talking now about like classic androgen deprivation therapy, stuff that's existed for at least a couple of decades, sometimes offered as punishment, in the 40s and 50s to gay men, to sexual predators and such. But it's a valuable therapeutic modality. Modality, I believe, is the right word for that, I guess.
It is.
Okay, thank you.
Yep.
Good. I mean, it's good to do these interviews because I pick up at least one or two things each one. The idea of there are all these new molecules in the last 2 or 3 years. You alluded to them. Our community's well aware. Enzalutamide, apalutamide, and on and on. At what point do those molecules come into play for guys who are just sort of now experiencing a post-initial therapy rise in their PSA?
So there is, so I'll back up and talk a little bit about the history of hormone therapy. It's worth knowing about this. Back early, in the early the 1900s, Men that presented with prostate cancer, with advanced prostate cancer, there were really no treatments. And it was obviously, and many of your viewers are aware that in its advanced stages, it can be very morbid. It causes a lot of pain, weight loss, and other issues. So there was actually a physician, Charles Huggins, who really discovered the hormone sensitivity of prostate cancer and really of breast cancer as well. He won the Nobel Prize in 1966 for this. It really changed the way. I mean, he had these incredible examples of patients that would come in. I actually knew him when I was at University of Chicago. He was in his 90s and would come in every day. You could set your watch by when he would come into his research lab. But he would often give the example of patients, with very advanced disease that when they were treated with hormone therapy, one quote was, "It was like Lazarus rising from the dead." So really changed the way this cancer was treated. Fast forward to the 90s and 80s and 90s, and hormone therapy was used very liberally. But then we began to discover that there were maybe more adverse effects associated with its use that we needed to be careful about its routine use in everybody. And this has now moved full circle to where we typically won't start hormone therapy until you begin to see evidence of disease clearly outside the prostate. So hormone therapy is initiated at that point. Now, the question becomes, when does abiraterone, enzalutamide, some of these other drugs begin to become utilized? And in men with hormone-sensitive metastatic prostate cancer, that's when we begin to think about the use of these drugs. The first study looking at androgen deprivation therapy plus another drug was done several years ago. Was what's called the Jarrard trial. I was actually a co-investigator on that trial, and it was actually giving men chemotherapy as well as androgen deprivation therapy for metastatic hormone-sensitive prostate cancer. And you think, well, we just saved chemotherapy for very advanced disease, but we knew it worked there. And essentially what you're doing is when you give this to patients with metastatic disease, it's sort of like a 1-2 punch. You hit them with androgen deprivation therapy, and then the knockout blow is the chemotherapy. And it was really remarkable because these men had profoundly improved survival with androgen deprivation therapy and this chemotherapy docetaxel. The field has evolved to also include in this situation androgen deprivation therapy plus abiraterone or enzalutamide. There are other drugs such as darolutamide, apalutamide that's also improved in this setting as well. And these are sort of super anti-androgens, if you will, these oral drugs, those three that I just mentioned. So if you're a patient whose PSA is rising and you have disease outside the prostate, in the modern era, we don't really recommend treating patients with just androgen deprivation therapy. We use these combinations now. And the combination that's recommended will depend on where the disease is and the extent of the disease. But it's important for your viewers to be aware of these other options that are now available.
Yeah. So combined with imaging and good doctoring, there's actually a chest of multicolored paints that really can extend life in ways that just didn't exist 4 or 3 years ago, and that's extraordinary, and relies heavily on the art of the doctor. As the patient, and we'll close this out in a minute or two. I do want to cover do you suggest the patient sticks with doctors like you, or should move into medical oncology?
That's a great question. This sort of interface between your doctors who are more focused on treating primary disease, radiation oncologists, urologists, and medical oncologists who tend to treat more advanced disease. And that often will depend on the situation that you're involved in. Some urologists feel very comfortable in managing patients with these kinds of situations. They're certainly trained to do this. There are situations that, and often if these tumors become hormone independent, which can occur farther down the line, often medical oncologists are best at treating that disease. So within this period of time where the PSA is rising, I think it's reasonable to have patients get a chance to talk to a radiation oncologist as well as a medical oncologist and really treat this kind of disease as a multidisciplinary approach. I mean, getting an opportunity to hear a number of different viewpoints about where your particular case should go.
Yeah, and also enlist an entire care team, people concerned about financial impact, the financial toxicity of cancer treatment, how to pay for things, how to identify good insurance plans, or how to deal with Medicare or Medicaid, or for those of our community who are in other countries, how to deal with their national health care. And how to deal with home life, whether you're single or partnered up or, perhaps supporting a child or something, how do you manage your cancer care in the face of life's other demands, and your own goals, Good. Dr. Jarrard, thank you so much for taking time to speak. Oh, actually, before I say thank you, one last thing. What kind of questions do you wish your patients in this particular presentation, of like post-treatment rising PSA, what are the top 2 or 3 questions you wish your patients would always ask you?
So I think it's important to talk to your doctor when the PSA begins rising about, ultimately, if the PSA keeps rising, at what point do you institute therapy? What are my options for therapy? That's an important point. And also, really reach out and talk to your doctor about what are the important components here. Again, we talked about this newer evolution of imaging, and it's important to be an advocate for your health. So I think we're well equipped in many places, and there are great physicians out there who know how to manage this disease. But be a health advocate. Question and help yourself. So I'd say that's one. But I think one final question is that I wish people would ask is, what else can I do? And because there are other non-medical things that I think are very important.
Well, you're referring to diet, exercise, that kind of
diet, exercise, those kinds of things.
Yeah, and those help, invigorate life, whether it's effective for cancer treatment or not, right?
That's true.
I mean, the whole point of doing any of these really, powerful interventions, these, sticking chemicals that affect your androgen levels and such. I mean, the point is to enjoy life. I mean, that's why you want to do it. I mean, it's not like you're going to, get a prize if you live an extra year. The prize is every moment that you're enjoying that extra year. Yeah. Yeah. Okay. Now I'll say thank you to you. But really, I mean, thanks for, every doctor has demands on their time that are beyond anyone's comprehension. So I'm grateful that you spent this hour with us. And I'm also grateful for the care that you show your patients and, the continued research that you're involved in, to keep finding better things to fix us. So thank you for that too.
You're certainly welcome. Take care.
Bye.